Yeah. Let's wait until we get everybody. Okay, Committee Member Anderson, just want to make sure everybody's back. Dr. Myers, are you back on the line?
I am.
Excellent. Before we go live with our public call, we just a couple of housekeeping things. Dr. Myers, can you confirm, are you going to need to leave the meeting at 2 p.m. today?
Yes, I am. Sorry.
Okay. No, that's completely okay. We understand. We have to have a quorum in order to, if the committee decides to motion some of these protocols today. Right now we have a quorum. So we want to we're going to have to shuffle the agenda most likely. And I just wanted to throw that out to you that the mailing related to short-acting opioid antagonists is one that we may need to punt to the end of the meeting because it may not be necessary to send that through to the April board meeting at this time because pharmacists are already allowed to prescribe that due to the law. So,
but we really have to get to the vaccine protocols.
Yes.
So we're going to shift those up in the agenda to make sure that we're able to get those motions done before Dr. Myers has to leave.
And so we're trying in the background, we're going to be chatting with our SMEs and because we gave them proposed times when to join the meeting. So we're just trying to get everything sort of set up for you in the background, but I think we are ready. I just start the recording and bring the public back on for the continuation of this current topic that you guys are discussing. Does that sound agreeable? Member Anderson?
Yes, that sounds agreeable to me.
Okay, very good.
My apologies.
Not a problem.
No problem. We just weren't sure that that we had two absent or additional absent committee members today. Okay. Ready, Staff Member Davis?
Yes.
Okay. Good to go.
Okay, welcome back. We are going to resume conversation about STI PEP. Just a second to get that next document open. The next document in this packet is the prescription template. Sure, I've got the track changes on. So I think based on earlier conversation today, we were talking about changing this to 28, which would be 14 doses. The delayed release to 14. And with that, I'll hand it back over to you, Smead Doyle.
Smead Doyle speaking. Yes, the prescription template, very straightforward, choice of 2 different products, and now it accurately represents the quantity as we had discussed, changing to adhere to Medicaid coverages provided by committee member Gibler. No other comments on this form.
Any committee member questions, comments? Next form, the provider fax.
Can you read that, respond to it? Can you say it's okay?
Back to you, Doyle.
Yeah. One moment, please.
Please.
With regard to the next document, the Dear Provider letter, it identifies that the why the patient had seen us, the regimen that was ultimately prescribed, the report out on the testing for syphilis, treponema antibodies, and gonorrhea, chlamydia, and some pearls for the physician that are associated with the the benefits of using DoxyPrep. The only recommendation that I would change on this form now is down at the bottom about the pharmacist monitoring of STI PEP, is that there's a checkbox. I see highlighting going on from staff member Davis about the CBCs and LFTs, and I agree with that deletion. And I would suggest that that box, rather than deleting it, would it be better if we were to say patient provided baseline order, patient provided order for baseline STI testing?
As a new bullet point,
Well,
not a check mark. Committee member, this is committee
Yeah.
member Gibler. I'm just asking if that's a separate bullet point
Yeah.
as presented now. Okay.
Smeed oil, I was thinking that it would be, in my mind originally, I thought of it, it was a check off box. So it demonstrates an actionable item that the pharmacist or pharmacy team did actually take. But in the protocol, we are now indicating that a order is given. And so a bullet point here seems appropriate. Is the bullet point redundant of your patient has been tested for and or indicated the following? Perhaps maybe moving that bullet point, patient provided order for baseline testing, underneath the subheading of your patient has been tested, and changing the title of that section in the middle of the page. So I'm thinking of inserting before the underlying test name of putting that bullet point in that we're copying from down below.
Got it. Hold on.
Yeah, it's actually a hidden table.
Yeah.
And we'd have to reword the bolded "your patient has been tested" to something else. Or just "your patient has been provided baseline orders and or they indicated the following."
This is committee member Anderson. Can we move order in front of baseline? So provided orders for baseline testing of, or is indicated for the following.
Is that
And
right?
maybe, yeah, and then add for in between indicated and the indicated for the. Thanks.
Smeed oil, by adding the "for," that would cause me confusion because it's perhaps the results, the baseline testing resulted in the following. Or yeah, or leaving the "for," which is crossed out. Don't delete the "for" that is crossed out, and then put a comma in there and or indicated the following. Yeah.
Sure, that's fine.
Yeah. Smeed Oil, I have no other comments on the page.
Any other committee comments? See any hands, so we will move to the last document in the packet.
Smeed Oil, this is the patient information sheet that would be given out to the patient. Again, it was amalgamated from CDC resources as well as other handouts that are given at other clinics using DoxyPep in San Francisco, Detroit, and other places. And I thought this was appropriate use language for good use of the drugs and how to follow up and with whom to follow up on the second page if they were having any issues that arose. And noting here on the follow-up and next steps, make plans with pharmacy or a different healthcare provider to get STI screening every 3 months. So again, that continues to be in line with what the committee had shown interest in keeping in the previous document of getting STI testing every 3 months, but knowing we can lag out to every 6 months if the patient is demonstrating some non-compliance issues. No other comments from myself.
Any comments from the committee members? Okay.
No, I mean, this is committee member Gibler. The only question I had is what others thought about the second key point, just actually stating the funding of the study and how it was published and when it was published, and if that's just like too much info for a patient education. Like, could it, and will it date itself eventually? Could it be say it has been found that using Doxy, or do we need to cite it? Is that
In some of, I'll hold off on my comments. There's another raised hand.
This is committee member Wickenhagen. I had the same thought about the NIH study. Again, just sort of reading level concerns, like above the 6th grade. And
yeah, that was I think what I was getting at.
Yeah.
And these are relative risk reductions, so I don't, that can even be misleading. But I like the point that it's not 100%. I think patients need to know that part. It doesn't completely prevent someone from getting in the infections, and that's the important part, I think.
Smeed Oil, I'm fine with the edits that are on screen to reduce reading load. The other resources that I used, patient handouts, actually did include this language or similar, and it seems as if a lot of rationale around it is the patient population has a inclination to be suspect of healthcare providers and their honesty, et cetera. And so it emphasized the importance of transparency in how this information and protocol was derived, and so and the potential results thereof. So that's why I had continued to include it here.
Okay. So that completes the committee's review of this protocol package. Just one thing I want to mention, because sometimes in documents, we make them all required or none required and various things. So in this package, all the documents are required to be used by the pharmacist except for the prescription template. They can write their own. I just want to make sure that if anybody has any comments or concerns about that. But that's the way this protocol is written and proposed to you today.
This is Committee Member Anderson. Do the others have a requirement to use the patient education and those pieces? There was a discussion earlier about that.
The birth control one is required by law. So that one we do require. The patient education handout is kind of a newer thing that we've been providing to patients. And I think it's probably 50-50 as to whether it's required that the pharmacist use that exact handout or that they give a handout at all, but it could be made optional. That is the committee's decision.
I guess I'm fine with making that part optional.
What do other committee members think?
Committee member Wickenhagen, I definitely am a patient education advocate, but I also understand you've got a limited amount of time too, so optional probably is best, but preferred.
I have two optionals. I have two more committee members. Can we get consensus?
Well, I like it. I do like it. So I don't. If others feel like it should be optional, that's fine. But I think the patient needs the information one way or the other.
This is Committee Member Anderson. I guess I'm only saying that because there is, I believe, in the pathway, like a requirement to give them some education about it, is there not? And maybe if there isn't, then we add that, because I guess my thought is just that, like I would like pharmacies to be able to adjust things if they can, but keeping the important points. And I say that only by like offering something by electronic means or, that kind of stuff that they like to do.
This Committee Member Myers, can we use the term recommended?
Staff Member Davis, you can. That's fine. We can do that. We haven't done that on any other protocol. I mean, by it being there, it's recommended, by just being present in the protocol, but we can use recommended.
This is Committee Member Anderson. I guess I'm fine either way. I don't need it to be optional. It can be required. We do have the ability for people to, or for pharmacies to convert these into electronic forms, right?
Yes, pharmacies, as long as they
Okay.
retain all the language in the same order, that they can convert them.
Okay, then yeah, I think that was all I was concerned about. I'm fine with keeping it then as a required.
Do I have consensus to keep it required?
Committee Member Myers, aye.
Committee member Wickenhagen, aye.
Yeah, that's fine with me. I think Committee
Right.
Member Anderson was almost convincing me, though. That was reasonable too. So I'd go either way, but just required is fine.
Then I will hand it over to Committee Member Anderson.
All right, thanks. So it looks like we have a proposed motion to approve this STI PEP protocol. Do I have anybody who is willing to make that motion?
So sorry, this is Staff Member Melvin. Committee Member Anderson, could you read what's actually on the agenda? Because it's a move, you need to move to recommend. Sorry.
Okay, so committee member Anderson, is there a motion to move to recommend the STI PEP statewide drug therapy management protocol? Looks like this is version 2 of 2024 as revised today to the Oregon Board of Pharmacy for review.
So move. This is committee member Gibler.
Is there a second?
Committee member Myers, seconded.
Great. All right, committee member Anderson approve. Committee member Gibler,
Aye.
committee member Myers,
Aye.
committee member Wickenhagen,
Aye.
and it looks like committee members Lee and Jones are still absent for the record.
Okay, motion passes.
Yes, so it looks like this motion passes, and we will move on to the next discussion to look at the protocol concept for, we're moving on to a different one for immunizations. Is that correct?
Yeah, Staff Member Davis, because we have a limited amount of time, there's certain protocols that we do need to make sure the committee has time to review and discuss. So we are going to jump ahead to mailing B3. That is about vaccines, and review all the protocol modifications for that protocol package. And then we keep adjusting the timeline today as needed. We do have we do need to take a lunch at 12, and we do have a hard stop from 12:30 to 1 that I do need to, that's when our SMEs, SMEs were only available during that time for tobacco cessation. So we need to make sure we will maybe popping back and forth. But I do have vaccine SMEs on the line because they were very flexible with their timing today. So if you are ready, I will hand it over to one of the vaccine SMEs to start conversation. Which person? Crystal.
Thank you. Thank you, Ian.
Yeah, thank you.
Thank you.
Introduce.
Yeah, so we have subject matter expert Crystal Sharp is on the line. I'm gonna let her she's got a team of people working on these. So I will let her introduce other people as they need to pop on. And then Crystal, if you'll just let me know which protocol to open first. We are gonna do the vaccines, and then as time permits to go back to travel medications. But I know these vaccine ones really do have to get motion today.
All right, sounds good. Yeah, thanks for accommodating us earlier in the schedule. I don't see that Amy's on. I let her know that we were moving up in the schedule. So if she's not able to join, I will probably just take over what she was going to present on as well. Let me just pull up my list of who's going what. Do you have the list of protocols that we're reviewing in front of you, or should I just list off which one I need pulled up?
You just tell me which one to open and I will open it.
Perfect. Okay, if you could pull up, the first one would be standard protocol for all vaccines, cover page, and assessment and treatment care pathway.
B3A. So we're also opening the document on the public call, so we just have to combine our efforts here. And Staff Member Davis, I just will point out that you'll notice on every protocol that I'm updating the rule number. That's something we can do without having a committee vote, but I'm just showing to you what the numbers will be, and then we'll hyperlink them once the rules go live on March 1st.
Okay, that sounds great. Thanks. So this one had minimal changes, but if you could scroll down. So the first change that we had proposed was removing the CDC checklist for determining recommended vaccines, because that link was actually no longer available. So we opted to remove that. And I think that was the only recommendation we had for that one.
Any questions from the committee? Okay, what's the next one?
Okay, if you could pull up the standard protocol for all vaccines managing adverse reactions. Thank you. Sorry,
That's
give me just a
creepy.
second. Yeah.
I
Okay.
failed to.
Oh, good catch. I'm sure you're doing that a lot lately.
Yeah. Don't remember it off the top of my head, but I think it's.
Okay. So if we can keep scrolling down. So we actually received comment from a pharmacist within the community prompting us to clarify some verbiage regarding requirements for our emergency kit. So the protocol did read that an adult cuff be required and a pediatric cuff, if applicable, if that pharmacist or site is providing immunizations to that population. But there was really no distinction that a large adult cuff size be required. And given that, I mean, personally, I have even had folks come in that did not fit a standard adult size cuff. So we opted to require both a regular adult and large adult cuff size, and then still keep the pediatric cuff required if they are immunizing pediatric patients. So that was the only change for this document.
Any questions from the committee on this change?
Prudent, Committee Member Wickenhagen, thanks.
Okay. Let's see the next one. Sorry, I got too many tabs open. Okay, so the next one that I would like to open up is the inactivated influenza protocol.
B3E.
You're not like.
Okay, so again, we received community comments on this one, which actually was really exciting to see that folks are using that feedback tool on the website. So just wanted to put that out there. But basically, we received the comment that there was some inaccuracies regarding the dosing for patients 6 months to 35 months on the protocol that we had initially published. So first section, vaccine schedule, table 3. I believe initially we had 2 tables that were separated out. One was for 6 months to 35 months, and then the second one was basically 3 years and up. So given that we had reviewed the dosing and corrected that, there was not really a reason to have 2 tables. So we did combine them into one and notated that the dose could be 0.25 mils or 0.5 mils based on age and formulation, which I will get to below, but that is the rationale for those changes.
I'm going to show this with no markup, just so it's a little cleaner for just a second for the committee to see. Now we'll go to markup. Okay.
All right, and then, so we did a thorough review of re-looking at the CDC's recommendations for flu vaccine, all available products, and verified what the appropriate doses were for basically 6 months and up, and made some changes because that was an oversight that we had missed initially. And then also added this column, I'm not sure what the committee thinks about it, but adding basically like the antigen amount of each vaccine, so it is clear for folks when they're looking at this chart. I did want to point out something that is noted on the bottom of the chart. So Afluria is pretty unique because the approved dose is 0.25 mils for ages 6 through 35 months, but 0.5 mils for ages 3 years and older. However, the CDC and the package insert reported that the 0.25 mil pre-filled syringe is not available. So if we're using the pre-filled, or if we're using the multiple dose vial, then they should be getting 0.25 mils out of that. So hopefully that's clear and makes sense. And then there was another caveat for the Fluzone quadrivalent. So as it says, approved for ages 6 to 35 months at either 0.25 mils or 0.5 mils. So I think this could potentially cause some confusion, but we did state that the 0.25 mil pre-filled syringe is no longer available. So if someone does have the pre-filled syringe of Fluzone Quad, they can use and administer 0.5 mils to 6 months to 35 months. So that is made more clear in this chart. And this verbiage was essentially taken from CDC. So that's the main change for this protocol.
This is committee member Gibler. When dashes are used, like in here, we're actually saying through age, right? Unless otherwise noted with a symbol of greater than or less than or equal to.
Yeah, so it should be through 35 months.
Okay.
Is that the appropriate notation, or is there?
I just want, as long as we're consistent,
Okay.
and then when there's exceptions that we're using the appropriate symbols, I think the reader or the pharmacist will get it. But I just want to ask.
Yeah, and I'm open to changing it to through, because I know there will be someone that will probably
Yeah, I
ask.
know. And the CDC will sometimes write through instead of a dash.
Okay.
So but it's okay. I mean, all these protocols have the dash, so I want to.
Yeah, thanks for that call out.
This is staff member Davis. My eye had actually caught that in the table and I was a little confused. So I think we should just go ahead and make that adjustment.
Okay.
That's fine.
So I'm making it as I'm reading this. Okay. Is there anything else in this protocol? It's adjusted.
Not from our end.
Okay. Any questions from the committee about these modifications or any feedback, other feedback?
This is committee member Wickenhagen. I appreciate the updates and the clarifications. Thank you.
Okay. Next one, may we please open the meningococcal containing vaccine protocol? Sorry, looking here. Okay, so a lot of you may have already heard that there was a new vaccine that came to market called Penbria. For those that have not heard of it, basically it is a combination of an A, B, C, W, and Y. So they call it pentavalent meningococcal vaccine. So essentially this was FDA approved for individuals 10 through 25 years of age. And essentially it is only approved for those that will be receiving men A, C, W, Y, and men B at the same visit. So as you probably could imagine, it's probably not going to be that popular, but it's there. So we added it. I did remove the previous what's new comment, the latex for Bexsero, because that was kind of older. If we want to keep it, we can, but it's not that new anymore. All right, if we could keep scrolling down. So this is just some additional verbiage. Basically, the men ACWY and men that B vaccines may be given simultaneously at different sites, or this new vaccine, the men ABCWY vaccine, can be given instead of those two vaccines. And then, yeah, no changes there. There was a little weird spacing. You probably saw that blank page. I don't know if you can fix that on your end, but
I can fix it.
Okay, so we created a new table to include this new vaccine, Penbria. So essentially, dosing is 0.5 mils IM for 10 through 25 years of age. They get the first dose on day 0 and then can get that second dose 6 months later. Again, it's only for folks that are getting the ACWY and B at the same visit. And then there's some verbiage to guide immunizers. Sorry, I'm just reading this really quick. So let's say they get Penbria as their first dose, and for some reason, they do not need the combination vaccine at their next visit. There is some additional guidance on how they can proceed to complete either that ACWY or Men B protocol if they're not going to be giving the combined vaccine. So they basically state that Trumemba can be given for any additional Men B doses if they don't need that ACWY component. And if the Men B component is not required, then they really can give any ACWY vaccine. So hopefully that is clear. There wasn't any changes necessarily to the Bexsero and Trumemba. I think what happened here was we were just trying to consolidate the table into one. I think they were separate tables before. And then we have just basically added the vaccine components for this new vaccine, its presentation, again, the FDA approved age range, and then note to Marisol in this one. Okay, again, this is really repetitious of everything I just said, but basically the indication for this vaccine is if they're getting the ACWY and then B together at the same visit. And then basically just gives information on how to proceed if they're not needing that combinational vaccine. And then just in more like in non-active ingredients in the vaccine itself. And then since the vaccine does have tetanus toxoid in it, we just wanted to make clear that this is not a substitute for tetanus vaccine. So that's why we've added that verbiage there. And then we have listed the reported side effects from the Penbria package insert. And then, so I'm open to committee feedback on this, but I recall for those that were present for the RSV initial protocol that we had a long discussion about removing, what's it called? Like reconstitution instructions. So based on that previous information, I decided that it might not be required to have that information in this protocol, as we discussed previously, that the immunizer will be looking at the package insert to determine how to appropriately mix it. And most of our other protocols don't have that information included. Okay, and then we have our storage information. And then updated references. And then, yeah, that was all the changes we had for that one.
Questions from the committee?
This is committee member Anderson. I am good with deleting that stuff about the mixing and excipients and yeah, that.
Hearing no other comments, seeing no other raised hands, going to ask which protocol would you like me to open next?
May we open the pneumonia protocol? Okay. So some new updates with pneumonia. Essentially, PCV13 has been removed from any vaccine recommendations for any ages. When PCV20 came on the market, it was still indicated for children, but that has since been removed. And this protocol has been updated to replace PCV13 with PCV15 or PCV20. Additionally, section B, so I will just say when reviewing this protocol, even I got a little confused. So saying that, I think a lot of immunizers probably get confused still with pneumonia. So as we go through the protocol, I'll show how some of the tables have been reworked to be more synonymous with CDC's tables and hopefully to make it a little bit easier to follow. And then section C, so we provided a little bit more information to clarify what conditions should be considered for that shared clinical decision making for patients 65 and older when we're considering if they should receive PCV20 if they've already received PPSV23 and PCV13. All right. So as an immunizer, I think that a majority of the folks that are getting pneumonia routinely are that 65 and older population. So I decided that it would probably be best to have the table for routine vaccines first for that population. And this chart is really just a rendition of what CDC has posted on their site. So nothing clinically different, just a little bit more succinct. And then we also do have the section for clinical decision making. We have more information below, but just showing that the patient can get a dose of PCV20 if they have already received PCV13 and PPSV23. And we know specifically what indications would warrant that shared clinical decision making.
Staff Member Davis, where should I be on the protocol with that statement?
Hold on a second.
I was still in the charts, and I'm not sure if you're still in the charts.
Let's stick with the charts and then I can go into that section later because I know there's a lot of moving pieces with this one. Sorry.
So we have the routine schedule chart, which you mentioned that there's not particularly a change from previously.
Correct.
This
Yeah.
just moved up in the protocol. And then you have the special conditions schedules.
Correct. So we have a chart for immunocompromising conditions because those conditions are actually different compared to the chronic conditions. So that's why we have two different charts.
Then you list them here.
Correct.
And then we have chronic conditions.
Mm-hmm.
Then you list those here.
Yes.
Then we have younger people with immunocompromising conditions. And I'll make the formatting work a little better.
Thanks.
And then we have younger people with chronic conditions.
Right.
Then you have younger people with cochlear implants or cerebrospinal fluid leaks. Then we're into the licensed vaccines chart.
Okay.
And then these were your recommendations for use. And this, all this green underline is just moved language. It's not new language.
Right.
And then here's your new language.
Yeah, so this was just to provide more clarification on who's eligible 65 and up for an additional dose of pneumonia PCV20. So basically those living in shared communal spaces, areas with low pediatric pneumococcal vaccine uptake, or with immunocompromising conditions, which we have defined above, or the other conditions listed here.
Any questions on that from the committee? Special conditions.
So this was something new that I actually found while researching pneumonia. So there's more information about pneumonia dosing, who's eligible, and the schedules that they should receive if they're getting a hematopoietic stem cell transplant. That one was not included in the previous protocol, and I do acknowledge it's probably pretty uncommon. So if we want to keep it, great. If not, I'm open to that too, but it was included. And then any reference to PCV13 was removed since we are no longer using that vaccine.
Updated references.
Yeah.
Any questions from the committee?
And from me.
This is committee member Anderson. There aren't any from me either.
Remember
Committee member
Wickenhagen looks
Myers.
great.
Committee member Myers agreed.
What is next, Crystal?
Okay. Assad, I know you had a meeting coming up shortly. Did you want to go next for yours just to make sure that we fit you in?
Yeah, perfect. I'll have you go next. Thank you. And mine was the coronavirus update. All right, good morning, everyone. So for the coronavirus, there was just really one new formulation of the Pfizer's Comirnaty vaccine. I think I've heard a lot of pronunciation of it, but the Comirnaty vaccine does have unique storage conditions as well. So we just added this in the what's new, that it comes in a pre-filled single-dose glass syringe, and that the glass syringe is stored in the refrigerator. It cannot be frozen ever in the from whether they receive it, shipment to before administration. So that was really the main new thing. And then if you scroll to the very bottom, we did add some more information on the storage conditions. Yeah, and just highlighting again that it cannot be frozen and stored in a refrigerator in the general storage and handling section. And then in our table, we did add the storage conditions for the formulation as well. And it's only for the pre-filled glass syringe. It can be stored in a refrigerator for up to 6 months. that's fine, but as long as it's not frozen at any time, and if it ever is frozen, it does need to be discarded. I think this was a pretty simple one. Unless you guys have any questions on it, that was all the main changes that we did, or only changes we did.
Staff Member Davis, I have a question, actually, looking at this note on the first one. Is that a general note for all the products? I was just looking to the left, it's talking about a very, very cold condition. But then the note says do not freeze. I guess, is that a general for Pfizer vaccines in general? Or is that note only supposed to be down here with the pre-filled syringe? That's my question.
I think we want, I mean, I guess we can remove, it was a kind of a repeat, but we wanted to put it and specifically call out the pre-filled glass syringe. However, if it doesn't need to be there twice in the general Pfizer, because we have it listed in for the, you know, like 2 boxes down. So if it's a duplicate, we can just remove it if it's going to cause too much confusion.
Is there anything else in this protocol that changed? I don't think so.
No, that was the only changes was the adding the new single dose.
Any questions from the committee?
This is committee member Anderson. Sorry, I missed that. Did we decide to remove that note at the top to make sure that we are only discussing that one formulation?
We facilitate committee discussion on it. I didn't get any feedback, so I hadn't modified it in any way.
Well, not necessarily like, but I noticed your point about that temperature off to the side, and that would make it seem very confusing if, you know, that seemed to say don't freeze, but then it says to freeze. I don't know. I liked the idea of taking that out.
This committee member Gibler, as I understand, all Pfizer vaccines can be frozen at those temperatures and stored till expiration date. That's what you're saying, right?
Except for this single.
Except for that one, yeah.
Except
That's
for
what
the
so that's why I think that note is important to leave in there. But that's how I like that note, actually, even though it's repeated down below, unless you want to delete the one down below, that might be more appropriate. Or just leave them both in there. But I think we have to leave the glass syringes note, not freezing those up here at the top for sure, because you're also saying that all vaccines can be stored until expiration at that temperature.
Staff Member Davis, I think what is confusing me is like if you look at the Moderna table, like the notes on the side, it's not separated out by section. And I think this one just never got merged in a way. And like normally this would have all been one section. Does that make sense?
Oh.
I think that's why I'm
committee member Anderson. Yeah, I think that's why I was.
That makes sense.
And so that's why my eye was like, hold it, we're on this line about negative temperatures and really cold, but I think it's just that maybe this should have been merged. Does that seem correct, subject matter expert?
Yeah, I think that Crystal, does that resonate with you? Because I think that makes a lot more sense, especially if I was to like look it up and I'd go to that table, it's all inclusive, and then I'd look over and see the exception. I think it makes sense.
Yeah, I agree. I think just merging it and then having the statement the one time is a little more clear.
And then one more question, since I was merging, should I have merged this ambient temperature section into that as well? Like, should there be 2 bullets in this notes? Like, don't freeze the single dose syringe and any unused vaccine should be discarded? Or is that note very specific to the ambient temperature section?
I mean, that vaccine really could be applied to any of the sections, given that if they are past their appropriate listed storage, that they would be discarded. I mean, I don't feel strongly about keeping that comment anyways. I'm not sure what the committee thinks, but I feel like this comment is common sense and might cause more confusion than not.
As committee member Gibler, I would actually agree. I would also agree with you to delete that statement about discarding, because if you leave it in there, then I'm confused about refrigerated. If there's any multi-dose refrigerated option still that you would not actually discard unused.
Correct. Yeah, I was gonna say the same. Yeah.
And you don't say it with Moderna, and it has the same sort of thing, like 24 hours at room temperature, right? Like, you don't have that comment. Okay. Any other comments from the committee?
This is committee member Anderson. I like those changes. I like that got merged and deleted.
Nancy, did you want to go next for polio, and then I can wrap up with the last couple? I think you're on mute.
Sorry about that. Hi, everybody. I actually was just looking at this and I'm finding a line that we may need to change.
Before we go, can you introduce yourself
Okay.
real quick?
All right.
Before we go, can you introduce yourself real quick?
Yeah. I'm Nancy Petrosky. I'm new to the committee as a vaccine SME, and I work as a medical editor for Shoreland Travax.
Go ahead.
Okay, so what is? Can everybody hear me?
Yes, I can hear you. Although
Yes.
Jennifer, yes, I can hear you.
Okay, sorry about that.
Although Jennifer got some repeating here.
Okay, no, I'm seeing myself. The video's on delay, so it's sort of weird. So I'll try not to look at myself. Okay, so for polio, after many, many years of it not being recommended for adults because of outbreaks that have been happening in the US and in other parts of the world, and from people traveling and coming back and putting others at risk, there are now routine recommendations for adults. But most adults in the US have received the polio vaccine, but these are for people, as you can see here, adults who are known or suspected to be unvaccinated or incompletely vaccinated. So they are recommended to receive the 3-dose IPV primary series. And then there is another caveat for this year's recommendations: adults who are at increased risk for exposure to polio, and that's defined in the recommendations, and they get an additional dose. So if we scroll down, so the 7 to 17 was changed to the just greater than 17 because this is the routine series for children. And then the adults, if you can scroll down a little bit more. So you can see again, that's less than 18. This was, travelers was taken out because before it was just travelers who were greater than or equal to 18. Now it's everybody who's unvaccinated, incompletely, or unknown. and the verbiage is here. And then another thing to note in bullet A is the last sentence that says complete the primary series. A complete primary series consists of at least 3 doses of IPV, or if they previously received the oral polio, that can count as well as one of the 3 doses. And then in B, adults who previously completed the full series and are at increased risk, and you can see those at increased risk were already there, but now they're recommended to be given a booster. And then the only other thing that we updated, yeah, so this was adults and adolescents 18 years. So it includes 18 years, so that's why the adolescents was taken out. And then one of the references was updated with the MMWR from 2023. So that's when all these changes were made. Which is number 2, reference number 2. So again, basically the pharmacist will now have to ask patients if they've received their polio, their entire polio series. So this is kind of a new thing for them to do.
Any questions from the committee? Any questions from the committee?
Sorry, we're having a little bit of technical difficulty.
Sorry, we're having a little bit of technical difficulty.
Give us just a moment, please.
Give us just a moment, please.
All right, can everybody hear us okay now?
All right, can everybody hear us okay now?
I can.
Nancy, can you put your self on mute?
Nancy, can you put your
goes away.
self on mute? I just want to see if the echo goes away.
Hold on, staff member Melvin had to leave the meeting and is coming back in.
All right.
All right, any committee members have any questions on polio?
Share screen again.
No questions from me, Committee Member Gibler.
Committee Member Myers, none.
Committee member Wickenhagen, none. Appreciate the information.
Subject matter expert Sharp, what would you like to do next?
Yeah.
Technical difficulties are continuing.
Okay. Still. Can't hear anything.
Crystal, could you come off mute if you can hear us?
Yeah, I can hear you. I just don't see the protocol up.
What do you need?
Yeah, which one? I'm sorry, our device timed out on this side.
RSV.
Thank you.
Okay, so we just added some additional clarification regarding the Abruzzo vaccine and administration during pregnancy, and then some more information on if it should be provided for subsequent pregnancies. So CDC specifically defines the window of opportunity, essentially being 32 weeks, 0 days to 36 weeks and 6 days of pregnancy. So we just provided that additional clarification.
Should that be through?
Yes, thank you. And then, so if we could scroll down a little bit, so it's recommended to provide the vaccine regardless if they've had RSV infection in the past. And then basically, if you're not falling in this window, then the RSV vaccine is not recommended. And then there is no ACIP recommendation for subsequent pregnancies to get a second dose. There's no data at this time, so we just added that information.
This is committee member Gibler, just someone under the bottom there wrote no data is and crossed out R. It's actually R is correct because it's plural. Data is a plural.
Thank you. And I think that was, we just updated. Nope. This, I think we were just trying to fix some formatting on that. So there was actually no changes past that portion.
Any questions from the committee? I see no hands, no comments. What is next?
Yellow fever. All right, so this one will be pretty quick. Essentially, they just updated the yellow book. So we updated references to reflect the new 2024 CDC yellow book. And I believe there's no additional changes on this one.
Yeah, it was all changes to yellow book references.
Yeah.
Any questions from the committee? Seeing no hands, hearing no voices. What is next?
Japanese encephalitis, and it's going to be same situation there, just updating references to reflect the new yellow book.
Any questions from the committee on this one? No hands, no comments. All right, what's next?
HIB. So under what's new, they actually removed the latex precaution or contraindication for PEDVAX HIB. So we included that. And I believe that was the only update. Ah, thank you.
I'll just do that, you know.
Okay,
Yes.
we'll do that moving forward.
Yeah. Remove the contraindication. And that's it.
Okay.
Any questions from the committee? Questions, no comments. What's next?
The last one, I believe, should be the tetanus containing Okay. So what's new? Basically, we have included recommendations to reflect that if TDAP is accidentally given to children 10 years of age, that this can be counted as their adolescent dose recommended at ages 11 and 12. And previously, this was considered to be invalid. And then essentially this is just a repeat of what was said in the new section.
Any comments or questions from the committee? Okay. Any protocols we missed? Anything we need to go back to? We've been checking it off our list too, so we believe you've covered them all. Hold on just a second. We're just triple checking our check marks. Okay, we are good.
Actually, can we open the TDAP protocol one more time? Sorry, Amy just sent me an email probably about 5 minutes ago. So I just want to make sure that we have the correct verbiage in there. Is it okay if I paste some text into the chat or no?
I don't think chat's turned on. I think you'll have to just email it to us and then I can.
Okay, sorry, I know this is the 11th hour, but I just want to make sure this is correct.
You can also read it to me.
Sure. Okay, so can we scroll down to the section? I believe it was section 5. Yep, yep, right here where we, yes, this page right here. So if you could scroll up to just so I could see section 1. Yes, okay. So I just want to make sure that this information is presented here. And sorry, again, I haven't had time to review this since we were presenting. But basically, persons aged 7 years or greater, DTaP is not indicated for persons aged greater than 7 years, which we have. If DTaP is administered inadvertently to a fully vaccinated child, should be age 7 through 9. So if we could correct that. An adolescent TDAP dose should be administered at age 11 through 12. And I just forwarded you this email. We could probably just copy and paste that text into this section instead, but.
All right, so for those on the phone, sub CI under section 8 now says DTaP is not indicated for persons greater than or equal to 7 years. If DTaP is administered inadvertently to a fully vaccinated child aged 7 through 9 years, an adolescent TDAP dose should be administered at age 11 to 12 years.
Okay. And then section 2, if DTaP is administered inadvertently to an under-vaccinated child ages 7 through 9 years, this dose should count as a TDAP dose of the catch-up series, and the child should receive an adolescent TDAP dose at age 11 through 12. Okay. And then section 3. Yep, you got that change. Okay. And then this,
if you could say it out loud.
Yeah. If DTaP is administered inadvertently to a person aged 10 years or greater, this dose should count as the adolescent TDAP dose routinely administered at age 11 through 12 years. And I think those were the only misses that we had.
And does anything need to change to number 4? Because that should now read 10 years. Fully vaccinated. Maybe? Maybe not. Okay. Fully vaccinated child aged 7 through 9 years receives Tdap. Tdap dose should not be counted as valid. Adolescent Tdap dose should be administered. Okay, that's the same.
Yeah.
Okay. The header was just confusing in what you sent me by email.
Okay, thank you for making those changes.
Yeah. And this changes are direct copy and paste from like the CDC recommendation.
Yeah.
Okay. Just so we know where we're getting this from. Any questions from the committee on these changes?
This is committee member Gibler. So just going through the vaccine schedule in section 3, those ages are all appropriate now. I just want to make sure we've captured everything in here as well.
Got it. Crystal, do you want us to take our lunch break and just give you a little extra time to take a look at this, and then we can do the motion right when we come back from lunch?
Yeah, that's perfect.
So it's right at 12 o'clock. So we're going to take a 30-minute lunch. We'll resume at 12:30. Crystal will let us know if there's any further updates that are needed to, especially this table. I read it real quick and I think it's right. I think it was just adjustments weren't made in that other section when the age range changed, but we'll let her double check that, and then we can motion, and then we will jump into tobacco cessation because they'll have those people on the call, and then we'll go back and do travel medicines. Okay? Thank you so much. We'll be back at 12:30.